Conference addresses the unique needs of the blood cancer community and offers the latest information, tools, and resources to help support Canadians touched by leukemia. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation, Expanding Access to Novel Treatment and Care for Acute Myeloid Leukemia. In this session, Dr. Brett Houston, hematologist and medical oncologist at the University of Manitoba, will speak about her work in clinical trials in finding ways to optimize care and improve outcomes for patients affected with acute leukemia, as well as expanding access to novel therapeutics for these blood cancers. Before we begin, let me introduce myself. My name is Catherine Yerkew. I am the Community Services Lead for the Prairies at the Leukemia and Lymphoma Society of Canada. I will be the moderator for this online event. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation. Due to the large number of participants and limited time, we may not be able to answer all of your questions. Also note that Dr. Houston cannot answer specific questions about a person's health, history, or status. Today's presentation will be recorded, therefore, we can watch it again on the website. Next slide, please. As we come together from across Canada, we recognize that we are on lands cared for by many Indigenous nations. We honor the First Nations, Inuit, and Métis peoples whose deep connection to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, and belonging and healthcare equity guides how we work to support and uplift everyone affected by blood cancers. Next slide, please. Are you looking for specific programs or resources, but not sure where to find them? We are here to help. You can connect with the community services lead in your area to receive personalized assistance and get connected to resources in your area. Reach out to us by calling toll-free 1-833-222-4884. Next slide, please. We know that having a diagnosis of AML can be very overwhelming, but know that you're not alone. There is a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-on-one support to help you navigate the blood cancer experience. Next slide, please. We invite you to visit our website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. Next slide, please. On our website, you will find tailored information and resources in multimedia formats to address the variety of needs and preferences, including those specific to AML. This includes fact sheets and booklets, like the one you see on the screen. Next slide, please. We have a podcast channel called The Blood Cancer Experience. You can find hundreds of podcasts for people touched by blood cancer and caregivers, and many addressing challenges that people living with AML face. We speak to experts about current topics such as treatments, diagnosis, and research. We will also hear personal stories from people touched by blood cancer. Next slide, please. And finally, some information resources to watch, like the series of animated videos on AML, understanding treatment options, side effects, and genes. Visit bloodcancers.ca to read, listen, and watch all these great resources. Next slide, please. In October, we launched the LLSC's Travel to Treatment study. This study is to measure and quantify how traveling for cancer treatment affects individuals and families. We want to gather and present information to decision makers to help them understand the real impacts of having to travel for treatment to improve support for individuals affected by blood cancer. This study will examine factors contributing to individual experiences, including finances, education, housing, and employment, to see how travel affects these important life factors. Please complete the survey using the QR code. You will also receive the direct link to the survey in a follow-up email 24 hours after this session. Thank you for taking a few minutes to fill this in this important survey. Next slide, please. It is now time to introduce today's speaker, Dr. Brett Houston. Dr. Houston is a hematologist and clinician investigator at the University of Manitoba and Cancer Care Manitoba. She is also a scientist at Cancer Care Manitoba Research Institute. Her research focuses on blood conservation and supportive care strategies to optimize care and improve outcomes for patients affected with MDS and acute leukemia. Thank you for being here today with us, Dr. Houston. Over to you.
Okay, perfect, Catherine. Thank you for the introduction, and thanks again for the opportunity to be here today. So as outlined, I wanted to talk a little bit about ways that we're looking to improve access to novel therapies for Canadians affected with acute leukemia, and talk about a few separate kind of research endeavors looking to achieve this aim. I do participate on a couple of advisory boards, although none of this work would influence the discussion today at all. So why are we here today? So we're here today because acute leukemia and AML is a serious blood cancer that can substantially affect patients and families once diagnosed. We're also here because research in cancer is hindered because AML and acute leukemia, while they affect us substantially, are not very common. And so it can be very hard to make significant headway in Canada in terms of accessing new therapies and conducting efficient research. And we're also here to discuss some of the newer efforts that are being made across Canada in an integrated fashion so that we can really increase our research participation and advance knowledge for acute leukemia across the country. So this slide is from a clinical trials to practice talk from AbbVie, but I think it really highlights some of the older kind of treatment options that we had for patients when they were diagnosed with AML. And this isn't too far back. This is just looking back at 2017. And as you can anticipate, I'm going to contrast that with where things are at right now and how quickly things have changed. So as you can see, in older adults or in adults who were going to receive less intensive therapy, really we were kind of left with azacitidine, maybe decitabine, or a little bit of low-dose cytarabine, but there wasn't a lot of effective treatment options that were available. But then when you look at some of the changes that have happened, even over the past 5 to 10 years, there's been a lot of progress made in terms of medications that are available to Canadians who are affected by AML, both for patients who are receiving more intensive therapy and also for patients who are receiving lesser intensive therapy. And this is a list here that highlights 8 new medications that we now have access to. And so what was previously a pretty simple flow sheet or kind of algorithm in terms of how we manage patients with acute leukemia, it's now become quite complicated, which is a lovely problem to have. But you can see that both patients who are receiving intensive therapy and less intensive therapy, we actually manage patients quite differently depending on patient characteristics, disease characteristics, certain molecular subtypes and contexts. And so really, a lot is changing, a lot has changed, and a lot continues to change. But really, that also raises a lot of questions as well. And I brought this case presentation kind of to highlight some of the nuances in terms of decisions that clinicians are making on an everyday basis, because as we have more therapies that are available, that really begs the question of what therapy is the best for this particular patient, given their values and wishes and characteristics and circumstances. And so, for example, here in this case, which is entirely a made-up case, of course, we have Mrs. Smith, and she's a 79-year-old nurse who has a history of osteoporosis. And she was well until she presented to her primary care physician's clinic a couple of days ago with some bruising and palpitations. Her lab findings are here on the left-hand side, but essentially a bone marrow is done and she is diagnosed with AML. But really, what happens if her white blood cell count is elevated? How does that change how we would manage Mrs. Smith compared to if her white count was lower? Similarly, what happens if Mrs. Smith lives in a remote area? What happens if it takes her 5 hours to drive to an AML treatment center? What happens if Mrs. Smith lives with her daughter and her young grandchildren who goes to daycare and commonly brings home viral illnesses? How does that change your management of Mrs. Smith? And does that modify the type of infection prophylaxis that you would use once she starts her chemotherapy journey? And so I mention all of this really to highlight that access to novel therapies is exciting, both probably from a patient perspective, but also from a clinician perspective as well. But that also raises a lot of questions about how to best use these therapies in a way that really benefits patients the most. And when we see patients in clinic, it's not a one-size-fits-all. As you can imagine, there's a lot of different factors that kind of weigh into how we manage somebody and how we support patients through their treatment. And part of that is based on the disease characteristics of the AML. So whether the white count is high or low, how significant the blood count abnormalities are. Sometimes we look at cytogenetic and genetic testing results that might inform treatment decisions. A lot of what we do should and often does really take into consideration patients' goals and their families' goals and priorities for care. And then also the treatment context. Do you live close to an academic center? Do you live in the community? How far is it to drive for a treatment? And kind of what are the local resources available and accessibility of those things. And so while those are things that we really consider when making clinical decisions on an everyday basis, I think the AML community is really challenging our research priorities to ensure that our research needs really parallel that of our treatment considerations. And so not just looking at what new drugs can we use, but also looking at when should we use them, how should we use them, who requires a modification, how can we best support people who are on these medications, and what research do patients want. And so for the purposes of today's talk, I really wanted to highlight 3 very new, but very exciting from my perspective, research initiatives that are being led across Canada that I think will have a really meaningful impact on acute leukemia management for Canadians moving forward. So the first kind of research initiative that I wanted to discuss was the Canadian Acute Leukemia Registry. It says AML Registry, but we also have a registry for ALL as well. So whether it's myeloid or lymphoid, both of those patients are captured. But really, this initiative was born out a couple of years ago when a group of Canadian hematologists and researchers decided they wanted to develop a comprehensive Canadian registry for patients who are affected with acute leukemia. And so why is this important and what does this mean? So it's pretty common for academic centers to have local databases, meaning local centers de-identify patient information and then have the opportunity to look back and see, you know, how many patients have been affected with therapy-related AML, what were the outcomes, how were they treated, how was their quality of life affected, et cetera. But AML is not that common. And so if you see 50 cases of AML a year, it would take many, many years to develop sufficient numbers in order to really meaningfully answer a lot of the questions that we want to ask. And so a lot of the really important questions that we want to know more about require larger patient numbers. And so that's really the motivation behind harmonizing as a country, not necessarily as a site, so that we can have a critical number of patients so that we can answer questions quicker. And as all of these therapies that I had highlighted before are introduced into clinical care, it's making a big difference in terms of how we're managing patients, but it's also raising a lot of questions. So, and questions that aren't necessarily answered at the time that the clinical trial was originally conducted. So for example, What is the optimal sequencing of therapy? Should you give treatment A first and then B, or should you give B and then A? And what kind of factors might weigh into that type of decision? We recognize that real life people are very different than clinical trial participants. And so when we then transfer these new treatments into the real world, how do patients do and how do they fare and what complications do they experience and how do they feel? We also are kind of learning a lot about some of the pathophysiology and genetic abnormalities that are specific to acute leukemia, and how does new lab technologies like minimal residual disease testing or specific genetic mutations affect our clinical decision-making and patient outcomes. Another reason to have a Canadian AML registry is that Canadian clinical practice can vary a lot from other countries. I would say it probably varies less from Europe, but can vary substantially from the US because as you're probably aware, but the drug access in the United States is a very unique situation that doesn't really apply to a country where our medications are provided. So, there are some therapies in the US that are not available in Canada and Europe in particular. In Canada, we have to consider cost and access, which again is unique to our environment relative to the US. And so really seeing how Canadians affected with AML do is a really important contribution because it provides a unique kind of answer to questions that are sometimes not readily available or transferable from a US population. So the registry was started through an initiative called the Canadian Leukemia Study Group. I mention this because it's again kind of a newer organization that started over the past couple of years that is a national network. It represents investigators from both academic and community centers. And it's really focused on treatment and management of acute leukemia across Canada. So this network is looking at a couple of different priorities. They are writing clinical practice guidelines to harmonize the delivery of care across the country. They're writing position statements. They're advocating at our national kind of drug approval process to try and increase the availability of novel agents for patients with acute leukemia across the country. So the Acute Leukemia Registry is one of the initial initiatives through the Canadian Leukemia Study Group, and it's being led out of Manitoba by Dr. Chris Paulson and myself. So the scope of the AML registry is really to ideally diagnose any new patient who has acute leukemia across the country. As I alluded to earlier, it's not restricted to a specific acute leukemia subtype. So patients with both myeloid disease and lymphoid disease are eligible. It's also not specific to patients based on a particular treatment intensity. So if you're receiving less intensive therapy in the community versus more intensive therapy in hospital, any and all patients would be eligible. We've had this active in Winnipeg as a pilot for the past couple of years, and we've actually accrued, it's actually a little bit over 90 patients over the past couple of years, which is like very close to the number of new patients that we've had over that time period. We've had very few patients who've been uninterested in participating, so we've had really excellent enrollment locally. And we're now expanding beyond Manitoba. So we anticipate that we'll have somewhere between 10 and 15 sites active across Canada within the next 12 months. So many sites have already submitted to their local ethics boards, and the contracting process is kind of ongoing. And we're just looking to finalize the next steps so that we can get this moving quite quickly. And this is a very kind of similar framework to what's been done with the APL registry. APL is a very rare subtype of AML that was started a few years ago because we really realized that within each center, we didn't see enough people to kind of learn from patient experience. And so The AML registry is now kind of expanding on some of the successes that we've had with the APL registry over the past few years. So the next research initiative I wanted to talk about was the Myelo-can trial platform. So the acute leukemia registry is really a way of following patients over time and collecting data on the patient experience and their response to treatment and outcomes and whatnot. But it's not an interventional study, meaning that when you were enrolled onto the registry, that doesn't affect your treatment. You're not going to be assigned a specific treatment compared to a different treatment. And so kind of building off of the acute leukemia registry, there's also a lot of interest and enthusiasm to build more of a sustainable clinical trial platform so that we can conduct multiple clinical trials for patients who have MDS and AML. And so we've called this Myelo-can, which is the trial platform. And within the Myelo-can trial platform, we intend to hopefully open like a number of trials that we can then use to advance our knowledge of AML management. So why did we want to start this? So we did this because we know that clinical trials are needed to inform best practice. In medicine, it's very easy to be swayed by the last patient or last few patients that you've seen, but we know that that's very flawed, and that's not a very scientific way about learning about something. And so really, if we're going to move the needle in terms of advancing and optimizing how we care for patients, we really need to study it in a systematic way. But we also know that clinical trials are exceedingly expensive and exceedingly inefficient. And the way that they've been done in the past is that they've functioned very disparate from clinical care. And what I mean by that is in many centers historically, and still a little bit at the present, although we're working on that, patients who are not on trial are kind of seen and managed very different than patients who are on trial. And there's the trial research people, and then there's the clinic nurse and clinical team. And that kind of redundancy and duplication is very expensive. It also is not really a benefit to patients either, because it can be very confusing to figure out who you're going to ask what questions to. And historically, trials have also been very personnel heavy. There hasn't been a lot that's been automated or integrated into clinic, and it's required a lot on manual data capture. Clinical trials often take a very long time to complete because, as you can imagine, it takes a long time to enroll the number of patients into the trial, and you have to follow them over a period of time. And so that might mean that, you know, from idea to trial completion, that might be 10 years. But if it's going to take us 10 years to answer every single question, then we're not being very efficient, and we're not moving the needle as quickly as we really need to. And then lastly, clinical trials are really motivated to protect perceived risks to patients, and in doing so often require many, many pages of consent forms. And while I 100% agree that patients absolutely should be informed about the risks and benefits of trial participation, I also think that we need to kind of factor in patient input into some of these consent methods, and we can really, I think, improve upon some of the traditional methods that we've been using over the past 10 to 20 years. Further, when we look specifically to patients who have acute leukemia is relatively rare compared to the number of people in Canada who have heart attacks or type 2 diabetes. Acute leukemia is not terribly common, and so it really does require a concerted effort and a substantial infrastructure in order to study these groups of patients. And then also kind of the recognition and the consideration of the fact that patients with leukemia have got a lot going on. They often have had their world completely rocked. They didn't see this coming. They're sick. They might be admitted to hospital. They're on chemotherapy. They're getting blood transfusions. There's lots of visits and they're overwhelmed. And we need to find a way that we can kind of acknowledge some of these limitations and work with patients so that despite these challenges that they face, they still also have the opportunity to participate in research if that's something that that is of importance to them. And so within Myelo-can, and I'll talk a little bit about how it works in the next few slides, we really are trying to take this as an opportunity to push the needle on many of these different things. So we have a patient partner group that we established a couple of years ago that we've met with consistently as we're trying to establish this framework. We're really looking at ways that we can optimize methods of consent to try and get away from like the 20-page stack of paper that people get. We're looking at ways of really making sure that consent is patient-centered and that it's conveying what people need to know and isn't protecting institutions from litigation. We are trying to build in efficiencies in data capture. So rather than doing everything on paper like we used to, we're looking to try and use electronic solutions to keep costs down and to increase efficiency. And we're looking to establish what we call a platform trial, but really it's kind of like a trial infrastructure that is intended to be enduring. So if you think about starting a trial, evaluating two drugs, it takes a long time to get a trial up and running. And I kind of think of every new trial requires it's like building a house. You've got to like establish the infrastructure. You've got to send to ethics. You have to do contracting. You have to come up with a data solution. There's a lot of kind of fundamental processes that one needs to have in place before the house is operational and up and running. But with a platform trial, we're kind of building the house, and then each individual question and each individual trial, we're just doing an addition off the back. And so there's a lot of kind of built-in efficiencies that are really, we're hoping will increase efficiency. So instead of taking 10 years to answer a question, we can answer many questions at once, and we can add and remove questions as they become relevant over time. This also has allowed us to establish a formalized network. And this is what we've done kind of over the past couple of years, where we have people from many centers across Canada who are kind of committed to participate in Myelo-can, again, to increase representation across the country and to kind of allow for different provinces to lead different questions based on priorities and from both patients and the investigators. So this is a list here of many of the investigators who are actively involved in Myelo-can at the moment. And this seems to be growing kind of from one week to the next. We continue to add people as they express interest. So I didn't want to get too bogged down in the details about what a Myelo-can kind of platform trial looks like. But essentially, if it's open at your site, for example, investigators and clinicians and clinic teams can then screen any adult who's diagnosed with either MDS or AML. And that doesn't matter if they are then going to receive intensive therapy, whether that's like induction chemotherapy or a bone marrow transplant, or if they're going to receive less intensive chemotherapy, because we've built in a structure whereby depending on how people are being treated, the certain studies may or may not be relevant to them. But at the very least, it kind of keeps the option open for everybody. And then as studies get added, then we hope to kind of increase the trial offerings to more patients over time. So this is very new. We have obtained funding last year to start our first pilot trial through Myelo-can. And so we've established the master trial protocol and the actual trial specific protocol. And it's, Health Canada regulated. It's been submitted to many RUBs across the country. The Ontario RUB approval is imminent. And we're working with site contracting to really kind of what we would call like build the house. We're establishing the framework. We've created the network, as I kind of alluded to previously. We have a network across Canada, and then we're also building collaborations with people in the UK and in Australia and New Zealand. We're coming up with a data solution. What we're actually trying to do and what we're going to do is we're actually going to build the data solution for the trial with the registry. So the real kind of motivation behind this is if you can imagine coming to clinic and then your team tells you, well, there's like these 12 research things, and then you have to fill out 12 different consent forms, and then you have to do like 5 different surveys based on quality of life. That's a real barrier to enthusiastic participation when you have a lot of other things going on. And so in many sites, we're harmonizing it. And so there's a lot of overlap between the registry and information that you would otherwise collect for a clinical trial. And so we're just gonna use the registry as the backbone, and then kind of add on trial-specific fields as we need to. In our site in particular, we actually just have one consent form. So if somebody was interested in participating in Myelo-can, the consent form is actually designed so that it talks about the actual trial itself and also the registry. And so we're not duplicating things unnecessarily. And these consent forms have been reviewed by patient partners as well to make sure that the context is understandable and that we're being as efficient as we can. And so actually from a patient perspective, beyond the initial consent, there's a lot of kind of how the registry and Myelo-can integrate are really just kind of behind the scenes. And it affects kind of the site coordinators and how they document data, but it's intended to kind of be an efficient way where participants can participate in both, but without the redundancy in terms of consent and logistics. So how are we starting? So as I mentioned previously, the advent of new therapies has raised a lot of questions in terms of how we can support therapy. One specific example is azacitidine and venetoclax. So that was a medication that's been available across Canada since early 22. And it's made a really big difference in terms of how we manage patients with acute leukemia who are being treated in the less intensive setting, so outside of hospital. But it does come with increased toxicity compared to some of the prior treatments that we've used, and it's really raised a lot of questions about how we can best support patients who are receiving this. So, off the top of my head, I can think of 50 different questions, but how often do we need to do blood work? Do we need to do a type and screen every time? Should patients get 2 units or 1 unit of red blood cells? What's the optimal platelet transfusion threshold? Should it be 10, 15, 20, or not at all? Are there other ways that we can reduce bleeding? So tranexamic acid is one option. It's a medication that is used to prevent bleeding in other settings. What should we be using to prevent fever and infection? Should we put people on antibiotics? Should we put them on antiviral? Should we put them on antifungals? Should we be using full dose? Should we plan to cut back after the first cycle? Should the cycle be given every 4 weeks? Should be every 6 weeks? So these are all kind of like questions, real world questions that are coming up in the AML community every day, and they would never otherwise be answered unless we had a systematic way to answer these questions. And so in Myelo-can, kind of the initial priority has been to try and look at different ways that we can support people who are receiving novel chemotherapy. And the first trial that we're looking at is something called the TXA trial, and TXA stands for tranexamic acid. And tranexamic acid is a pill that people take in other settings. So it's used in people who have congenital bleeding disorders like von Willebrand's disease, for example. It's also used commonly in the postpartum setting to prevent postpartum hemorrhage. And it's used in the perioperative setting as well. So people at time of surgery, they get tranexamic acid, and it's been shown to reduce bleeding. And so the question that many of us are wondering is can we give this medication to people who have acute leukemia and a low platelet count, therefore which places them at increased risk for bleeding? And if we give them this medication, does it prevent bleeding? And so We this is our kind of initial trial that we're running through the Myelo-can platform. And we're looking to enroll patients with a platelet count of under 30. They're going to get a pill twice a day for 60 days. And then we're going to evaluate how the platform works and does this medication reduce bleeding to those who are at risk. The next kind of question that we're looking at is about infection prophylaxis. So patients with acute leukemia on treatment are often neutropenic and are therefore at increased risk for fever or infection. And we know that people often use antibiotics to try and prevent fever and infection, but it's never actually been studied in the outpatient setting. So we're kind of transferring our knowledge from other contexts to the outpatient setting and assuming that that's helpful, but we've never kind of justified that practice. And so another kind of question that we're looking at is, does the use of a preventative antibiotic reduce fever infection? Or are we just giving people more pills to take and the side effects associated with those medications? And then this is kind of similarly true. Another trial looking at ways to prevent infection. So G-CSF is an injection that people can get that stimulates the bone marrow to make more blood cells, more white blood cells in particular. And so it's used in other settings to kind of mitigate infection risk. And in trials, outpatient trials recently done, there's been a lot of variability in terms of whether investigators have used G-CSF or not to try and improve the blood counts and minimize risk of infection, but we don't know if it actually helps. And so another question that we're kind of considering is whether or not the use of G-CSF might be helpful to prevent fever and infection for patients who are on chemotherapy. But that's really kind of a starting point. And so we're starting small and we're planning to scale up hopefully quickly over the next couple of years. But it does require a commitment towards future trials, and it requires a lot of forward planning so that we can kind of get a number of trials up and running as quickly as possible. And so there's other ideas that are kind of circulating throughout the Myelo-can community. We might look at dose modifications to commonly use chemotherapy. We might look at ways to optimize transfusion support. We might look at the earlier use of palliative care. We're also hoping to expand the platform into industry studies as well, so we could conceivably study novel agents throughout this platform as well. And we're working with patients as well to kind of identify patient priorities in MDS and AML research. So we sent a survey through AMAC and LLSC a couple of years ago that informed the initial trial ideas for tranexamic acid and infection prophylaxis. Really, if we're looking at ways to optimize supportive care, it feels egregious to do so without patient input. And so that's a really strong kind of like foundational concept to this platform, is making sure that the questions we're answering are meaningful to patients. And then the next kind of research initiative, it's a very big one, and we've been waiting many, many years for this, is something called the Myelo-match trial. And you're going to say, well, do they all have to sound the same? And I know it's a little bit unfortunate. So Myelo-can is Canadian and currently looking at supportive care. Myelo-match is a US and a Canadian initiative, and it's a big initiative. And I started hematology in 2016, and it was kind of in works at that time, and only in 2024 has it recently opened. So it's a pretty exciting time for care providers who are managing patients with myeloid disease. So Myelo-match is really focused on really creating a precision medicine solution to patients who have myeloid cancers. And so Myelo-match is a group of clinical trials that are a little bit interconnected, designed for patients who have MDS and AML. And really their focus and their priority are to study novel and often targeted agents for patients who are newly diagnosed with AML and then subsequently throughout their treatment course. So ideally, what might happen is if somebody is newly diagnosed with AML, they have the complete workup done. We identify what their mutational status is. We enroll them into a frontline trial that targets mutation X. They're on that trial, and then we follow them over time. And if they have a disease relapse or if the disease changes in any time, then they get kind of re-reviewed and then entered into another targeted trial based on what their AML characteristics are at that time. So it's intended to be kind of a set of trials that follow people over time. And as you can imagine, that takes a lot of organization in order to make this happen. And this was really motivated by the fact that targeted therapies are really becoming quite common for patients with AML. So here I've listed kind of 5 common mutations that have targeted therapies that are either currently in use or are likely to be in use moving forward. So IDH1 we have a targeted agent called ivosidenib. IDH2, we have a targeted agent called enasidenib. For FLT3, there's a number of different targeted agents. Midostaurin and gilteritinib are currently available, and quizartinib is currently undergoing a funding review. And then KMT2A and NPM1, revumenib takes a few times to get that off the tongue, is a new agent that is in phase 3 trials now. And many of the Canadian centers are opening this phase 3 trial. So you might be hearing more about this over the next year or so. So this is a schematic for Myelo-match, and the actual details here don't really matter, but this kind of alludes to the comprehensiveness of the Myelo-match platform, whereby a patient is newly diagnosed, they undergo their disease testing, so we can learn more about the specifics of their AML and any specific targeted therapies that they might be a candidate for. Then there's a group of initial treatments or trials that they would be considered for based on the molecular profile of their disease. And then there's kind of subsequent trial options as well. So there's a group of trials looking at MRD testing, or if we use really fancy tests to detect very small amounts of disease, does that help or improve how we care for patients with AML? There's another group of trials looking at what's the role of transplantation in the management of AML. And then there's other trials looking at kind of second-line genetic targets for patients should they relapse down the road. And so in Canada, we have a couple of trials that have recently opened, and we have many more trials that are hopefully going to be opening within the next year or two. And so I've only mentioned 2 here, but this is a trial that is looking at, it's called AL6, and the names are kind of a little bit unhelpful, but this one is looking at in younger patients, so patients who are receiving induction chemotherapy, who have intermediate risk AML, and it's looking at using MRD testing or fancy testing to optimize treatment for patients. And MRD testing, while it's interesting and it's something that we talk a lot about at research meetings, hasn't been something that's routinely been integrated into AML care yet. But this study will hopefully help us answer that question so that we can better tailor and risk adapt what we're doing for people based on their needs and based on their disease profile. And then this is a really complicated but a very exciting trial called ALC8. And this is a trial open for patients who are receiving induction chemotherapy, but it's randomizing you to 5 different types of intensive chemotherapy. Because as you know, in the schematic that we had put up at the very beginning, there's a lot of overlap in terms of who could receive what, and a lot of them haven't been compared head to head. And so we're trying to see which of these 5 looks like it's most effective for newly diagnosed patients who are at increased risk. So I hope I didn't confuse you too much. We talked a little bit about the Acute Leukemia Registry, which is an observational study that's following people over time. We talked a little bit about the Myelo-can platform, which is a Canadian trial initiative that's kind of integrating with the Acute Leukemia Registry to study supportive care strategies for patients. And then we also talked about a very large US and Canadian basket trial called Myelo-match, which is looking at more targeted therapies for patients with AML. There's a couple of other trials that are likely to influence AML care in Canada over the next year or two. And so I mentioned them here. This is the Agile trial. It was recently published last year, and it's looking at the combination of azacitidine and ivosidenib in patients who have IDH1 mutated AML, who are receiving less intensive therapy. So this would be another treatment option available for patients who would otherwise be considered for azacitidine and venetoclax. So this medication is this trial is currently being reviewed with Health Canada, and we're hoping to have access to ivosidenib in this treatment setting in 2025. The other trial that was recently published that is likely to impact management is the Quantum First trial. And so this was again published very recently, but it was looking at people who are being treated with intensive chemotherapy who have a FLT3 mutation. Does the use of a targeted treatment called quizartinib, which is a FLT3 inhibitor, does that improve outcomes compared to standard of care? And then the other trial, this is going to be a phase 3 trial. There was the Augment 101 trial, which was looking at revumenib in patients who have NPM1 or KMT2A mutated AML. It's called a menin inhibitor. And so again, it's just another targeted therapy that we're able to kind of layer on based on our increased understanding of AML treatment over time. So I hope I was able to convince you that acute leukemia research is well underway across Canada. There's a number of Canadian centers that are prioritizing AML research, whether that's observational or trial-based. We're looking at ways that we can try and integrate research into the clinical care so that when patients come to the clinic, they're not a clinic patient or a research patient, but they're a patient who can participate and experience both. And that over time, I think there's been an increased emphasis on patient priorities in research, and that is echoed throughout the Myelo-can platform as well. So that is all that I had prepared. Perhaps what I'll do is stop sharing, and then we can answer any questions that you may have.
So thank you for sharing your expertise and insight with all of us, Dr. Houston. As you mentioned, it's now time for our question and answer period. If you haven't done so already, be sure to use the Q&A box in your Zoom webinar panel to type your questions. As we mentioned earlier, due to a large number of people in limited time, we may not be able to get to all your questions. Dr. Houston will not be able to answer specific questions about a person's health history or status. So I would like to just start with the first question. How does one get added to the AML registry?
So that's a good question. So the AML registry is intended to follow people over time. Probably the first step would be to ask your local care providers if the registry is open at their site, and kind of go from there. Unfortunately, in Manitoba, it's easy to do that. In other provinces, it's not yet open, but it's hopefully something that people can ask to be added to moving forward. It's also hopefully something that your care providers will mention to you, so it shouldn't necessarily be upon you to seek it out. Hopefully it will come to you.
Right, and just to add to that, do they are they accepting newly diagnosed children?
The AML registry is specific to adults, so it's 18 and older. Yeah.
Okay.
Yeah.
So my next question, several new drug therapies for AML have recently received FDA approval in the US, especially for relapsed and refractory cases, and for IDH1 and IDH2. and FLT3 gene mutations. What initiatives or regulatory efforts are in place in Ontario and Canada to fast track approval and availability of the therapy? And do we have a timeline for the introduction, given the limited and costly options that are currently available?
Yeah, so that's an excellent question. So I kind of alluded to a bit of the discrepancies in access to some of these novel therapies compared Canada and the rest of the world compared to the US. A couple of years ago, there was a number of trials and a number of new agents that were FDA approved, but not available in many countries. So in the relapse refractory setting, single agent ivosidenib, single agent enasidenib, single agent gemtuzumab, for example, they were not publicly funded in many countries. That's part of why the CLSG started as a bit of a physician advocacy group to help advocate for the AML community. There's also LLSC advocacy committees as well. But essentially, when a medication goes to Health Canada for review, there is a decision, is it going to be submitted by the drug company? And sometimes it's not. And if it is submitted, then there's a formal review in terms of how well it works, how expensive is it, and is it something that is manageable in a public health system? And sometimes the answer is yes. We often hope that it's yes, but sometimes it's just not something that's feasible. And so as Canadians, we sometimes do have to pick and choose a little bit what medications become publicly funded. But hopefully CLSG and other advocacy committees will increase access. Also, a lot of the trials that have been done recently have demonstrated a more significant benefit. And so if medications work better, they're more likely to be available.
Good, thank you. So next question, are there longitudinal studies tracking AML patients who transition from treatment and into the various stages of remission?
So the registry would be the answer to that. So the AML registry follows people over time for 5 years. How long we follow you depends a little bit on what's going on, but it's intended to kind of follow people throughout their journey. So if they started on intensive chemotherapy and then had a bone marrow transplant and then relapsed and then went on less intensive therapy, there would be a mechanism to follow patients in all of those contexts, regardless of whether you're on treatment or in remission.
Good, thank you. So much of the research on second generation inhibitors, especially venetoclax, targets older treatment AML patients, 70 plus. Are there studies or data on outcomes for younger or previously treated patients?
Yeah, that's a wonderful question. So the VIALE-A trial came out in 2021, and it looked at azacitidine and venetoclax in older adults with AML. And then we realized that it works really well. And so there's a lot of interest in trying to expand the use of venetoclax into younger patients. And so in the Myelo-match basket trial, so like the third research initiative that we talked about, the ALC8 is actually looking at the use of venetoclax in younger patients. So it's combining venetoclax with 7+3 induction, it's combining venetoclax with Vyxeos induction, and it's using azacitidine and venetoclax in younger patients. And so there's actually going to be 5 different treatment arms, and then we can really see, does venetoclax work, and if so, in what combination?
So are there timelines for studies expanding patient demographics for these therapies?
I don't know if I entirely understood what you meant, but if a center has ALC8 open, then a patient over the age of 18 receiving intensive therapy could be randomized into this trial to potentially receive venetoclax.
Okay. So considering the success of HIV treatment through multi-drug HAART, could similar combination approaches be applied to AML to improve outcomes?
So yes, so there are a lot of trials, and I couldn't show them all because that would be dreadful to listen to, but there are triplet combination trials that are underway. So there's combinations looking at azacitidine, venetoclax, and FLT3 inhibitors. There's triplet combinations looking at azacitidine, venetoclax, and IDH1 or 2 inhibitors. And I think the kind of bottom line is that, yes, they're very effective, but B, they're very toxic. And so there's more study that kind of needs to be done to kind of learn about how we could implement it in a way that is manageable for patients without increasing toxicity. But definitely combination therapies are likely to be the way of the future.
Okay, and this is going to be our last question. So, does Myelo-can integrate in any way with PEDAL, the LLSC program, which is focused on pediatric acute leukemia?
So it does not, because Myelo-can is more of an adult platform, whereas it sounds like PEDAL is more of a pediatric. That's not to say that it necessarily won't, but the reason we haven't started there yet is that pediatric research is a little bit different. It's often done through the Children's Oncology Group, and it's a completely different set of trials. And so we wanted to make sure that we had the infrastructure established in adults, and then we can look towards expanding into the pediatric group down the road if there's interest amongst the pediatric community.
Perfect. Thank you so much, Dr. Houston. Your expertise is very valuable for us. Before we sign off, I'm just going to get you to pull up the next slide. I just want to remind everybody about the upcoming conferences this week. CLL, November 6th, starting at 1 o'clock Eastern. CML, November 6th, starting at 3 p.m. Eastern. Acute lymphoblastic leukemia, ALL, November 7th, starting at 3 o'clock Eastern, and how to actively participate in your cancer care, November 8th, beginning at 1 o'clock Eastern Time. Next slide, please. So we would also like to thank AbbVie, Astellas, AstraZeneca, Bristol Myers Squibb, Jazz Pharmaceuticals, Johnson & Johnson, and Novartis for their support in making these conferences possible. Next slide, please. Please remember that we are all here to help you. You can reach us by email, by visiting our website, bloodcancers.ca, or by calling us toll-free. Please note that a short survey will be sent to all participants after the presentation. Just please take a moment to respond, as it helps us plan future events. And last slide, please. So thank you for being a part of this webcast today. Take good care of yourself. Thank you.